So our next topic we'll be going over is observing, recording, and reporting. Your observation skills, recording, and reporting are essential, especially when performing your care plans. The facts about observing, recording, and reporting. You spend more time in the home with patients than any other staff member. Therefore, you may be the first to recognize change in their condition. By observing and reporting these changes, you can increase their chances of recovery. You should report changes in patients, even if the nurse will be making a visit that day. In addition to helping your patients, your observations and reporting also helps the nurses and therapists to do their jobs better. Good observing, recording, and reporting also helps your agency. During a survey of your agency, the surveyor will review the notes to see whether you did the important parts of your job. Those include recording the duties you were supposed to perform, as well as whether or not you observed and reported anything out of the ordinary. So methods of observing patients. Many people think observation means simply looking at something or someone. However, there's many different ways you should observe patients. They include the following. So looking, which is what we most commonly do. For example, bruises or rashes, problems with transferring and ambulating. Touch or feeling, for example, cold, clammy skin. Listening to the patient's body, for example, congested coughing. Listening to what patients report, for example, pain and nausea. Smelling, for example, foul-smelling urine. On every visit you make to the patient, you will be constantly observing. It never stops. Some of the most important observations you'll need to make include their skin. That's the first thing you typically see on somebody, their skin. Because you're giving or assisting with the bath, you have more opportunity to observe skin than anyone else. You must especially pay attention to things that are not normal for this patient. Some of the things you should always look for include color. Is the patient very pale? Are there areas of discoloration, especially in the legs and the feet? Are there reddened areas, particularly on bony prominences? So bony prominences will be your elbows and your hips. Are there any bruises? Are the lips bluish? Temperature. Does it feel especially hot or cold anywhere? Is there warmness or coolness only in certain areas? Swelling. Is there swelling or puffiness? Look around the eyes, the joints, the legs, and the feet. Open areas. Is there any new skin breakdown? Are there any cuts, scrapes, cracks, or skin tears? Pain. Does the patient show signs of pain when you touch them in certain areas? Numbness. Are there some areas where the patient say he or she feels numb? Smell. Is there an odor coming from the skin, especially from dressings? That could be a sign of infection. Eyes, ears, and nose. Eyes, is there any crusting or discharge? Is there any redness around their eyes? Ears, what about any drainage or any discharge? It's important to record on the visit note as soon as possible. You must always record the assigned duties you completed. A rule of thumb is that you also need to record anything that you reported. So if you didn't document it, it didn't happen, okay? Keep in mind that the recording must be objective. In addition to your assigned duties, you should record in your visit note what you observed that needed to be reported, number one. Number two, the date and time you made the report. And number three, the name of the person to whom you made the report. So let's do our case study on observing, recording, and reporting. Ms. Martinez is an 80-year-old patient with an indwelling catheter. So that is a catheter that does not come out. Lakeisha visits 2 times a week to assist with the shower and personal care. The nurse visits once a month to change the catheter, and every 2 weeks to supervise the aid services. One morning, Lakeisha notices that Ms. Martinez did not seem quite as alert as usual. Her skin was its usual color, and her breathing was the same as always. The first thing Lakeisha did was look at the urine in the drainage bag, which was its usual clear light yellow. She started to assist Ms. Martinez to sit on the side of the bed so she could use her walker to go to the bathroom for a shower. Ms. Martinez seemed to slump towards the right and did not use her right arm to steady herself. Lakeisha steadied her and then suggested she lie back down and go to bed. Once Ms. Martinez was lying down, Lakeisha asked her to raise her right arm. She was not able to do a full range of motion, and the arm was weaker than usual. She also had some weakness in her right leg. Lakeisha asked Ms. Martinez whether she had noticed the weakness, and Ms. Martinez said it only started that morning. Lakeisha told Ms. Martinez that she thought she should report this to the nurse and encourage her to lie back down and rest. Ms. Martinez asked Lakeisha not to call the nurse. She said that she had these spells before and they always went away. Lakeisha talked with Ms. Martinez and told her that there was a definite change in her and it was important for the nurse to know about it. She called the nurse to report the weakness in Ms. Martinez's arm and leg and stated that she did not think that she could safely transfer her into the shower. The nurse advised Lakeisha to do a bed bath rather than a shower, not to assist with any exercises, and to keep Ms. Martinez in bed. The nurse talked with Ms. Martinez and told her that she would be calling the doctor and would most likely make a visit. Lakeisha completed the cares for Ms. Martinez and did her documentation. She wrote in the visit report that the right arm and leg appeared weak and that Ms. Martinez slumped towards the right when she sat on the side of the bed. She also wrote that Ms. Martinez said she noticed the weakness that morning and reported having the weakness before. Lakeisha wrote that she informed the nurse, giving the nurse's name in that report, listing the date and time of the phone call. She also wrote that the nurse instructed her to give a bed bath instead of a shower, not to do any exercises, and not to get Ms. Martinez out of bed. The next day, the nurse called Lakeisha to tell her that Ms. Martinez was in the hospital. The weakness in her arm and leg was an early sign of a possible stroke, but because of Lakeisha's observation and reporting, they had been able to give Ms. Martinez medications to prevent her from having any long-term effects. Something to think about. Were Lakeisha's reporting and recording objective? Why or why not? Are these things you would have done? List as many reasons as you can think why it's so important for Lakeisha to report what she observed. So the way that Lakeisha reported, she was objective. Why is it so important for her to report in the manner that she did?
Near the end, it mentions that they were able to give the medication to the patient in time to prevent any long-lasting effects from a possible early sign of stroke.
Right. So because she documented date, time, that helps us to determine onset of symptoms, how long it's been going on, to determine in the healthcare world if we can give those medications that patients need. At this time, I'll give you all a few minutes to answer your questions and we'll come back for a review. Okay, so question number 1. Which of the following is not objective recording? A, I don't think he feels good today. B, there's a new reddened area the size of a dime on his left hip. C, he says he is lightheaded today. Or D, his urine is much darker than usual. A, I don't think he's feeling good today. That's more of your opinion. That's not objective. 2, which of the following is true about observing and reporting? A, you should only report what you see. B, it is not necessary to report that the patient says she is dizzy if she doesn't act like she's dizzy. C, you should not report something if the patient asks you not to. Or D, you should report changes you observe in the patient. D, you should report changes you observe in the patient. 3, which of the following should you always report? A, the duties listed on your assignment sheet were all done. B, the patient said she fell last night. C, the patient's vitals if taken. Or D, all of the above. B is in boy. The patient said she fell last night. Yeah. So which of the following should you always record on your visit note? A, the duties. We're going to keep going. That's the repeat. 5, it's not important to record and report a change in the patient if the nurse is making a visit later on today. True or false? It is not important to record and report a change if the patient, if the nurse is making a visit later on today. False. So B. Which of the following is true about objective and subjective recording? A. Subjective recording is recording exactly what you saw. B. Objective recording is recording what you think about the patient. C. Subjective recording is the type of recording you should use. And D. Objective recording can describe something you observed by touching. So 6, what would it be? The answer would be D. Objective recording can describe something you observed by touching. So 7, why is it important for a home health aide to know what to report? A, reporting changes in patients may increase their chances of recovery. B, changes you report will help the nurse to do their jobs better. C, reporting is an important part of a home health aide's job. And D, all of the above. D, all of the above. Which is the best example of objective recording? A, I don't think Miss Bell takes care of herself. B, Miss Bell says she feels bad, but she looks all right to me. C, Miss Bell says she was sick to her stomach and threw up 3 times last night. Or D, Miss Bell whined all during the visit. 8, what would that be? C, Miss Bell says she was sick to her stomach and threw up 3 times. 9, it is not necessary to record something in your visit report if you reported it to the nurse. True or false? False. You should still record. 10, and final question. Which of the following is true about recording something you reported? A, you should always include what you observed when you make the report and the name of the person you reported to. B, it's better to wait a few days to record so you can think about it for a while. C, all you need to record is call the office. Or D, you should always include your opinion about the meaning of what you reported. A, you should always include what you observed when you made the report and the name of the person who you reported to. So at this time, we have completed the in-service training for preventing falls with patients, observing, recording, and reporting, privacy, confidentiality, and HIPAA, and caring for the patient with pain. We hope that you will use the information that you learned today to continue to go out and provide the best care to corporate care's clients. Thank you. All right, I'll take those from now. All right, so let's review. Question number 1, HIPAA is true or false? So HIPAA is a federal law that protects the privacy of a person's health information. True or false? True, so A. 2, which of these is considered confidential information under HIPAA? A, the patient's name. B, what's wrong with the patient. C, the home care services that the patient is receiving. Or D, all of the above. D is in dog, all of the above. 3, what information about patients is protected by the HIPAA regulations? A, information that is in the computer. B, information that is written on paper. C, information that is said out loud. Or D, all of the above. D is in dog, all of the above. 4, the HIPAA regulations about privacy are only for nurses, therapists, and other professionals. They do not apply to home health aides. True or false? False. B is in boy. 5, true or false? The patient must give permission before the aide can release information about him or her. True or false? True. So A. A patient's daughter arrives from out of town while you're making a visit. She says to you, I can't seem to get any straight information from my brother. Can you please tell me what's wrong with my dad? How should you answer her? So A, tell the daughter that her father has cancer and you think her brother should have told her. B, tell the daughter you don't really know. C, show the daughter the care plan and folder so she can see for herself. And D, tell the daughter that you cannot share information about her father and suggest that she discuss this with her father and brother. D is in dog. Question 7, true or false? You could be fined for sharing patient information with someone who should not receive it. True or false? That is true. Letter A. 8, true or false? It is not a problem to discuss patient information with other staff members, even if they are not taking care of the patient. True or false? False. Question 9, what should you do with papers that have patient information on them when you no longer need the information? A, throw them in the trash can at home. B, give them to your children to use as scratch paper. C, take them into the office and place them in the to be shredded bin. And D, put them in the patient's trash can. C, take them into the office and place them in the to be shredded bin. D, the scheduler calls you at a patient's home to give you another assignment. There are people who can hear what you're saying. What should you do? A, repeat the name and address of the other patient so you can make certain you have it right. B, tell the scheduler that there are others who can hear you so you can't repeat the information and she may have to give you the information several times to make certain you have it correctly. C, tell the scheduler to call someone else since people can overhear you. Or D, tell the scheduler you can't talk and hang up. B is in boy. Tell the scheduler there are others who can hear you, so you can't repeat the information and she may have to give you the information several times to make certain you have it correctly. You have now completed privacy, confidentiality, and HIPAA, and we'll go on to observing, recording, and reporting. So your observation skills, your recording and reporting skills are very important, especially when documenting on your care plans. The facts about observing, recording, and reporting. You spend more time in the home with patients than any other staff member. Therefore, you may be the first to recognize changes in their conditions. By observing and reporting these changes, you can increase their chances of recovery. You should report changes in patients even if the nurse will be making a visit later that day. In addition to helping your patients, your observations and reporting also helps the nurses and therapists to do their jobs better. Good observing, recording, and reporting also helps your agency. I gotta pause. I'm sorry, y'all. All right. We are going to go over the answer to our questions. So question number 1, what is the most accurate indication of pain and how severe it is? A, when the patient is crying with pain. B, when the patient tells you about the pain. C, whether or not the patient is being uncooperative with cares. Or D, when the patient shouts at you. B, so when the patient tells you about pain. 2, which of the following is true about reporting pain to the nurse, therapist, or supervisor? A, there is no need to report the pain if the patient has taken his or her medicine. B, you do not need to report the pain if you think the patient is just whining and doesn't really have pain. C, you need to report pain only if you need to change what is on the assignment sheet. Or D, you should always report the pain the patient is having. D, you should always report the pain that the patient is having. 3, which of the following behaviors may indicate a patient is having pain? A, restlessness. B, doing crossword puzzles or other activities. C, singing and humming, or D, sleeping? A, restlessness. Question number 4, what is something you might do that may help patients having pain? A, position comfortably. B, give a soothing bath. C, control loud noises and bright lights. Or D, all of the above. D, all of the above. Question number 5, true or false? The most important thing about chronic pain is that it can never be managed. True or false? So question number 5, the answer is B, false. 6, which of the following must you do when the patient tells you that he is having pain? A, if you don't believe it, tell him just not to worry about it. B, tell him he should not take pain medicines or he'll get addicted to them. C, accept and respect that he's having pain if he says he is. Or D, believe him only if he has other signs of having pain. C, accept and respect that he is having pain if he says he is. Question number 7. When you begin to do range of motion on patients, she tells you it is making the pain in her leg worse. What should you do? A, notify the nurse, therapist, or supervisor and follow his or her direction. B, continue the exercises since they're on your assignment. C, stop the exercises but chart that you did them. D, do all the exercises except the legs. A, notify the nurse, therapist, or supervisor and follow his or her direction. Question 8, true or false? You should look for signs of pain even if the patient does not tell you he or she is having pain. True. Question 9, which of the following is true about chronic pain? A, it's never as bad as the patient says it is. B, it can be continuous or it can come and go. C, patients will always tell you if they have chronic pain. Or D, all of the above. So B, chronic pain can be continuous or it can come and go. 10, which of the following behaviors might you see in patients who are having pain? A, holding their hands over the parts of their body. B, crying. C, being less interested in things they're usually interested in. Or D, all of the above. All the above is D, correct. If you could place that packet to the back of the sheets that you have, and we'll pick up with privacy, confidentiality, and HIPAA. Before we get started on this section, I'll have you go to the answer sheet and place your name and today's date on the answer sheet. All right, so let's talk about privacy, confidentiality, and HIPAA. Starting off with some facts first. How many of you know what HIPAA is or have ever heard of HIPAA? So if you've gone to any healthcare facility, doctor's office, they should have given you a little spiel about HIPAA, but we'll go over that right now. So HIPAA stands for the Health Insurance Portability and Accountability Act. It's a federal law that protects privacy of persons' personal health information. HIPAA has many rules your agency must follow. Some of those rules apply to you and your role as a home health aide as well. There may be penalties if you break the HIPAA rules. You could even be fined. HIPAA regulations cover many areas, but privacy of information is one of the most important for you to know about. Privacy of information means that anything you say or write about a patient must not be overheard or read by anyone unless that person has a right to hear or see the information. He or she can have that right only if the patient has agreed that they may have the information. So let's go through some situations. 1, talking on the phone. Do not talk about a patient over the phone if there's anyone who might overhear. If the scheduler calls you at a patient's home about a change in assignments, never say anything that might identify any patient. When you have to call to report an observation about a patient, make certain that no one else is around other than the caregiver can overhear anything that you're saying. If you receive work-related messages on your home answering machine, do not allow your family to listen to them. Do not leave messages on the patient's answering machine unless the patient asks you to. Use your cell phone carefully. Never use the phone to relay patient information in an area where others might overhear the conversation. Discussion with others. Use the need to know rule. Do not discuss a patient even with another aide. If there's no need for the other person to know about the patient, don't gossip. Never discuss a patient in a common area of the office. This includes hallways, open areas, the bathroom, or the reception area. Do not discuss one patient inside another patient's home, even if you're talking with the nurse who takes care of both patients. Never discuss the patient with an interested neighbor or even a family member unless you know for certain the person assists in the patient's care and or the patient does not object. Ask the nurse or therapist when in doubt. Paperwork. Guard your visit notes and other papers so that no one else can see them. Don't leave papers lying around at your house, in your car, or office. Make certain that all paperwork taken into a home is kept confidential. Do not put papers containing patient information in the garbage. Shred this information. To learn and follow your agency's policies on security and confidentiality of patient information. Provide information only when you're certain that the patient does not object. If the patient is not present, ask if it is all right to discuss the information and give the patient an opportunity to answer or say no. If the patient is not present, you will likely need to ask your supervisor whether or not you should discuss this information. The information you would disclose should be directly related to the person's need to know, and it should be a person involved in the patient's health care. So what we've learned so far is that you only discuss patient's information if the patient has given you permission. And remember to use the need to know rule. Be careful in your day-to-day conversations. When you have paperwork at home, if you take your care plans home, make sure that they don't have any information just left out for your family members to see. So our case study, Hannah and HIPAA. Hannah recently attended an in-service, much like the ones that you're doing, program on privacy and confidentiality. Before leaving for her first visit, Hannah listens to her voicemail using the receiver and not the speaker. She deletes the messages containing patient assignments and directions. Hannah rides the bus, so she must take all of her papers with her. She keeps them in her clothes bag. Her day goes something like this. The first visit is to Mr. Smith. Just before she's ready to leave, Mr. Smith's neighbor dropped by for a visit and asked Hannah how he's doing. Hannah replies, "It's good to know you're interested, but I can't really discuss Mr. Smith with you without his permission. I'm sure he will be glad to see you and you can ask him how he is." The second visit is to Mrs. Jones. While helping her into the bathtub, Hannah notices that there's a big bruise on her leg. She needs to report this to the nurse. There are visitors in the kitchen, so Hannah uses the phone in Mrs. Jones' bedroom to call the office. The third visit is to Ms. Black. The nurse who has come to do a supervisory visit is also Mrs. Jones' nurse. As the nurse is leaving, Hannah goes with her to the door, and when they are on the porch, she tells the nurse about Mrs. Jones' bruise. A staff meeting is next on Hannah's schedule. As she walks into the busy room, one of her coworkers said, "I hear you're taking care of the mayor's wife. What's she like?" Hannah tells her coworker politely, "We really should not discuss patients unless we're having a care conference." The fourth visit is to Mr. Blanco, who has severe effects from a recent stroke. At the end of the visit, his daughter asks Hannah what she thinks about his progress. Hannah knows the daughter is Mr. Blanco's caregiver, and also the information can be shared with her. She answers, "I think he did better with his exercises today, and he seems to be swallowing better. But you might also want to check with the nurse and therapist and see what they think of his progress." The fifth visit is to Mrs. Johnson. Hannah is preparing her bath, and when she returns, she notices that Mrs. Johnson's granddaughter is looking through her papers. Hannah picks them up and moves them to the top of the dresser, saying, "Why don't I get these papers out of your way? I'm sorry I left them there on the table." All right. At this time, we'll pause and I'll have you all to answer your questions. I'll give you a few minutes to complete those. Things that you think he might have done. Would Antoine have done anything different if Mr. Otto had fallen while he was there instead of before? And then what is the best way to respond to a patient who asks you not to report something? So let's go through that first one. What would you say are some very important things that Antoine did in reporting this fall?
He removed glitter, suggested better lighting from the sun and at night light.
Okay.
He also elevated the toilet seat to help prevent, falling while trying to get on or off.
So he did some of those same things that we talked about. Making adjustments, cleaning clutter, elevating the toilet seat.
Grab bars.
And grab bars. Anybody else?
He also did the exercises to help with the range of motion.
Yep, range of motion exercises.
And he watched him use the walker every day, every time to make sure that he was using it.
Right, so observe proper use of his walker as well. So what would Antoine have done if Mr. Otto had fallen while he was there versus when he wasn't there?
If he was there, then he would have checked to make sure if he was still alert and unconscious.
Right.
If he wasn't, he would have called EMS services. And, if he was, he would have checked the patient over for any bruises, asked him if he had any pain, and still called the office to make sure everything was okay, and possibly called EMS if it was a bad injury.
Right. So the key to that is if he was there, of course, assessing for consciousness, calling emergency services at 911 when indicated and necessary, and always, no matter what, report these fall incidences to the office. Okay? And now we'll go to the next page. I'm going to give you all a few minutes to do these questions, and then we'll review. Ready? So good morning and welcome to Corporate Care's in-service training. My name is Chandra Mansell and I'm a registered nurse. This morning we'll be going over 4 topics: preventing falls in the home, caring for the patient with pain, privacy, confidentiality, and HIPAA, and observing, recording, and reporting. So the first topic, preventing falls in the home. Before we do anything, move forward and get right into this topic, I want you to go ahead and write your names on the top of your sheet. Thank you. So as we know, day to day, we may deal with some clients who can't get around that well. They may need a walker to get around, a cane, or sometimes they just sit in a wheelchair, right? So for those patients who do what we call ambulate, walk, they need something to help them so that they don't fall. So we're going to focus on how you can prevent falls while in your clients' homes, okay? I'm going to ask you to follow on with me. This is going to be an interactive class, so it requires your participation in order for us to move forward. All right? Okay. So preventing falls in the home. The patient wears only socks. Let me see yours. So we're going to follow up here. So why is it important to attempt to prevent folks from falling and keeping them safe? Why is it really important? To prevent injury, right? So hazards in the home, they increase the risk of falls, right? So more than half of the people who fall in their own homes. Most often it's while reaching for an object or while attempting to transfer. Many of these falls could be prevented by some simple measures to make the home safer. Problem areas include the following listed below. Floors. So clutter. How many times do you go into a client's home and you see clutter all over the ground? Hazards. Cluttered arrangement of furniture, loose throw rugs, objects on the floor such as papers, magazines, books, electrical wires, and even pets. So cats with those long tails that you don't see and you end up tripping up and falling over, things like that. Lighting. So inadequate lighting in any area, especially near stairs, bedrooms, and bathrooms. I wear glasses sometimes. And I know I need adequate lighting to see where I'm going. So just imagine some of your older clients need lighting to see where they can go as well. Bathroom. Toilet seat is too low. Slippery bathtubs, no grab bars, no bath chairs or bench. So a lot of times our elderly clients cannot get in and out of the bathtub without assistance. So they might need a jerry chair or a chair to sit down in to take a shower or a bath. Stairs. So again, clutter. It comes back again. Not only is it on the floor, but it's on the stairs as well. Broken or uneven steps, loose or broken handrails, torn carpets, light switches out of reach. Let's talk about the kitchen area. So poor placement of items, things used most often to be closer to need to be closer to waist level. Shiny floors. Why shiny floors? Right, they're probably wet. Using chairs as step stools and spills not cleaned up. And also in the bedroom. Your bed is difficult to get in and out of. Bedside lamp, hard to reach, and no night light. Again, older clients who have poor vision already, they can't see, so they need light. While it's true that a nurse or therapist should check the home for these hazards, it's often the home health aide, so you guys, who recognize these dangers in the homes. It's important that you assist your patient in reducing these hazards when you see them. Always report to your supervisor when these are hazards which the patient either cannot or will not correct. So if it's a cluttered home and you keep going back and cleaning up, and every day that you come back, it's worse or the same because the client has then placed clutter back into the floor, that's something that you can report. So what to do when a patient falls? If a patient falls while you're in the home, you should what? Follow agency policy, which usually includes the following. First, check to see whether the patient is alert and awake, and call emergency medical services or 911 if he or she is non-responsive, and then call the office as well to make them aware of what's happened. If the patient is alert after the fall and complains of pain, particularly in the hip or other joints, don't move the patient. Moving the patient could actually cause more injury than anything else. Cover him or her with a blanket and call the office and follow the direction of the nurse, therapist, or supervisor. If the patient is bleeding or cut, Administer appropriate first aid, so a Band-Aid. Notify the office about the fall, even if there does not appear to be any injury. Sometimes the patients will say, well, hey, I don't want anybody to know that I fell. I understand that, but your job is to report the fall if it happened, especially while you were there and present. Document the fall in your visit report, including actions that you took, and complete an incident report according to agency policy. So let's flip over to the next page. So in summary so far, if a client falls in your presence, if the client is still awake, alert, you want to notify the office, still call emergency medical services or 911. If a patient reports falling while you're not there, what should you do? We'll go over that. Find out as much as you can and when and how the fall occurred. Carefully examine the skin for bruises or broken skin during the bath. Report the information about the fall to the office, and in your report, document the report of the fall and that the office was called. Okay, so now we'll go over a case study that discussed the risk of falls. Antoine visits Mr. Otto 3 times a week. Mr. Otto is 75 years old and has had a stroke. I think that might be important to note that he's had a stroke. He also has congestive heart failure and arthritis, and has taken many different medications. He uses a walker. Remember, we just talked about walkers, and is a little afraid of ambulating because he fell last summer, even before he had the stroke. Antoine has been seeing Mr. Otto for 2 months. Over that time, Antoine has helped remove a lot of the clutter in Mr. Otto's home. He suggested that Mr. Otto have his son put in better lighting and a night light in the bedroom and bathroom. The nurse arranged for an elevated toilet seat and grab bars to be installed in the bathroom. Antoine helped Mr. Otto rearrange these items in his kitchen so that the things he uses most are not in hard places to reach. He follows the assignment sheet and assists with range of motion exercises and makes certain that Mr. Otto ambulates or walks 150 feet every visit. He carefully watches Mr. Otto to make sure he's using his walker every time and that he uses it correctly. So although the nurse, Antoine, and Mr. Otto have taken measures to reduce the risk of falling, Antoine is aware that Mr. Otto remains at risk because of his medical condition, stroke, his age, his medications, his use of a walker, and especially the fact that he's fallen before. On a recent visit, Antoine noticed bruising on Mr. Otto's arm and a small scrape on his hand. He asked Mr. Otto how he got the bruise and scrape. Mr. Otto told him that he slid to the floor while getting out of bed the other day. Antoine asked Mr. Otto some more questions about the fall and whenever he was having any pain and whether he was having pain anywhere else. Antoine told Mr. Otto that he was going to let the nurse know about the fall. Mr. Otto asked Antoine not to call the nurse, he said. I wouldn't have told you about it if I knew you were going to tell. Now my son will want me to move into that assisted living place he's always talking about. Antoine reassured Mr. Otto that nothing about his condition will be shared with his son unless he gave permission. He also told Mr. Otto that it was important for the nurse to know about the fall. Antoine called the office and reported the fall. He wrote on his visit report, patient says he slipped while getting out of bed last Tuesday and slid to the floor. He has a dark bruise around the size of a quarter above his right elbow and a small skin scrape on the back of his hand with no pain. Reported fall to the nurse, including the name of the nurse. The nurse talked with Mr. Otto's doctor. They decided that some physical therapy might be helpful for Mr. Otto, for some strengthening exercises, and to develop a new home therapy program for Mr. Otto to follow. At the bottom, it says something to think about. Let's list some of the very important things that Antoine did correctly in trying to prevent falls. Are there any other things you think he might have done? Would Antoine have done anything different if Mr. Otto had fallen while he was there instead of before? What is the best way to respond to a patient who asks you not to report something? So let's do this something to think about activity. So it said list some of the very important things that Antoine did correctly to prevent his falls. And I'll let you go ahead and list it quickly. All right, so question number 1. Which of the following does not seem to increase the risk of falling? Being taller than average, using a cane or a walker, taking many different medicines, or all of the above? Which of the following does not seem to increase the risk of falling? A, correct, so being taller than average. Number 2. Which of the following is true about falls? A, there is nothing you can do to reduce the risk of falls. People who have regular exercise are more likely to fall, which is B. Choice C, people who have several chronic diseases are more likely to fall. And D, people who live in older homes are more likely to fall. So again, which of the following is true about falls? Chronic diseases, yes. So C. Question 3, or statement 3, it's true or false. It is not necessary to report a patient's fall if it didn't happen while you were there. True or false? False. Question 4, how many people over the age of 65 fall each year? A, 1 out of every 100. B, 1 out of every 3. C, 1 out of every 10. D, 1 out of every 25. And the answer is actually C, 1 out of every 10 patients fall. 5, which of the following hazards in the home may lead to falls? A, loose throw rugs. B, broken or uneven steps on the stairs. C, a toilet that is too low. Or D, all of the above? All of the above. So the answer is D. Question 6. What is one action you should take when a patient falls? A, tell him it's all right, that you won't tell anyone. B, call his family right away. C, help him if he's having pain. D, call the office. So again, question 6, what is one action you should take when a patient falls?
Call the office. It says not to help him out. I think his family's important.
So tell him it's all right is answer A. Call his family right away is B. C, help him up if he is having pain. D, call the office. So this is a tricky question because I look at it and I can see C or D to help him up if he's having pain. So if you assess and you see that nothing is out of place, no deformities, you can help him up if he's having pain to get him off the floor. And then D. So C would be the answer, followed by D. Okay? 7. Which of the following is true about elderly people who have fallen? A, they always break a bone. B, they're at a higher risk of falling again. C, they will always report a fall. Or D, they should always go to the hospital to be checked out.
We should go to the hospital and get checked out if they're having pain.
Okay, I can see why you say that. The answer is B. They're at a higher risk of falling again. Once you fall, it only takes one fall for you to become a high-risk fall patient. Only one fall. Question 8. What is the very first action you should take when a patient falls? Call 911, which is A. B, get him up as quickly as possible. C, check to see if he is awake or alert. D, write it down on your visit report so that you don't forget. C, check to see if he is alert/awake. 9 is a true or false. Falls do not happen often when a person is attempting to transfer. True or false? False. Do y'all see why that's false? Okay. 10. Which of the following is not true about falls? So not true. A, falls are the leading cause of injury death among older adults. B, most falls occur outside the home. C, wearing only socks or improper shoes increases the risk of falls. Or D, patient with joint disease are at greater risk of falls. So which of the following is not true about falls? B as in boy. Most falls occur outside the home. All right, and that is our review for preventing falls in the home. Please make sure that your name's on the top of each one of your sheets. You can place it to the back of the stack of papers that you have, and I'll get them at the end. The next topic we'll go over is caring for the patient with pain. Before we get started with this one, if you could go to your answer sheet. This one has an answer sheet. Place your name and today's date at the top of your answer sheet. It looks like this. There we go. Okay, so flip back to the very front and we'll go ahead and get started. So caring for the patient with pain. The facts about patients with pain. Pain is hard to describe. It is a very personal experience. In the nursing world, we always say pain is what the patient says it is, not what you think it is. It's true that some people are able to deal with pain better than others, but when a patient tells you that he or she is having pain, you must accept and respect that. The most accurate indication of the presence and severity of pain is what the patient tells you. Remember, it's what they say, now how they look, and what they do. You must always report it to the supervisor, nurse, or therapist when the patient tells you that he or she is having pain. Pain is sometimes described as acute or chronic. Acute pain usually comes on suddenly and is more intense. It often happens because of an injury or surgery. Sometimes it can be a warning that something is wrong, such as the pain caused by a heart attack. Patients with acute pain are more likely to tell you they're having pain. Chronic pain can be continuous, or it can come and go. It can also be intense as well. Sometimes people with chronic pain may not tell you they're hurting since they feel it's something that they have to live with. You'll need to look for some behaviors that are common when people are having pain. Many of your patients have chronic pain that is better sometimes and worse at others. Such diseases as severe arthritis or cancer can cause chronic pain. Chronic pain can and should be managed. There are several reasons that patients may not actually tell you that they are having pain. Sometimes it's the way they were brought up. The pain is to be endured, and that complaining about it is a sign of weakness. Others don't take pain medicines because they're afraid that if they take them now and the pain gets worse, the medicine won't help anymore. Sometimes the patient does not want to be more of a bother to the family. Many patients are afraid of becoming addicted to pain medication. So the next question is, how do you know if they don't tell you? So let's try to figure that out. If the patient does not tell you that he or she is having pain, there are other things you can look at that may give you clues. Often when patients are having pain, they may show certain facial expressions, such as grimacing, looking sad, or looking wiped out. Have you ever just had a client and they just look exhausted? So that look of pure exhaustion could actually be an indicator that they're experiencing some pain right now. They may hold their hands over a certain body part. So holding your elbow if it hurts could be a sign of pain as well. Or gently rubbing the area. Sometimes they are restless and just cannot seem to get comfortable. They may have more trouble following your directions and assisting with their cares. Some patients may be less talkative than usual or less interested in things they're usually interested in. They may moan or cry or even tell you they want to be left alone. Patients who are usually in a good mood may be irritable or short-tempered. If you notice these behavior, ask the patient if he or she is having pain. And remember that the patient's pain or the client's pain is always what they say it is, not what you think it is, not what the behavior appears to be. So what can you do? Mostly you spend the most time with your client than their families during the weeks. So it's important for you to know your client, become accustomed to the things that he or she does on a daily basis. It's very important that you let the nurse, therapist, supervisor know that the patient is having pain. Report where the pain is, when it started, how the patient describes it, whether the patient has taken any medication, and if so, what and when. There may already be instructions on your assignment sheet to tell you some things to do for the patient who has pain. Here are some things that may help. Practice good positioning. Make certain that the position relieves pressure and rests the area where the pain is. Point number 2, pace and plan the activities you need to do with the patient. You may need to go a little slower than usual. Point number 3, ask the patient what has worked in the past if he or she has the same pain from before. Point number 4, try to interest the patient in something. Sometimes music or a favorite television show helps take their mind off the pain. Sometimes talking about their families or animals or even past events in their life will help as well. Be careful when trying to interest the patient in something. Some people do not want any of these things, and it actually may make them worse. Point number 5, control the patient's room as much as you can. Pay attention to the lighting, the temperature, and the noise level. Increased noise can bring on pain. If a patient is extremely hot, it can bring on signs and symptoms of pain as well. Try giving a soothing bath. Sometimes patients feel better when they are touched. So offer to give a back rub or gently wipe their face. And that was point number 5. Point number 6, be supportive. You must assume patients are having pain if they tell you they are. Do not make light of it. And point number 7, and the final point, do not do anything that makes the pain worse unless you have been specifically instructed to do so by the nurse, therapist, or supervisor. Even after you've told them it makes the pain worse. If there are activities such as exercises or a shower that are likely to increase the pain, call the nurse, the therapist, or the supervisor to report that they are increasing the patient's pain. So let's go over some important points to remember when taking care of patients in pain. Number 1, the patient's pain level is what they say it is. Believe patients who say they're having pain. That is the most important thing I can tell you thus far. Do not let your personal opinion decide that they're actually in pain or not. 2, notify the nurse, the therapist, or supervisor when the patient reports pain and follow his or her direction in changing what you do for the patient on this visit. Look for other signs of pain, even if the patient denies having pain. Don't be afraid to ask whether the patient is having pain. Point number 4, provide supportive care during your visit. 5, document the presence of pain in your visit note, as well as the fact that you called the nurse, therapist, or supervisor to report the pain. will now complete a case study on caring for a patient with pain. The case study is titled, Susan and Darlene Have Patients with Pain. Susan is visiting Mrs. Sampson, an elderly lady with rheumatoid arthritis. This morning, Miss Sampson seems quiet and withdrawn. That could be a sign of pain. She says she didn't sleep much last night because of the pain in her hips and back. Susan says, well, you'll feel better after we get your exercises and shower done. Susan starts the range of motion exercises, and Miss Sampson asks her to stop because it's making the pain worse. So Miss Sampson verbalized what made her pain worse. Susan responds, well, you know, the best thing is to just keep going and continue these exercises. Miss Sampson starts to cry. Susan tells her, you know, crying is not going to help anything. The pain can't be all that bad, and you should be used to it by now. I need to get you done so I can be on time for my next patient. She insists that all the cares on the assignment must be done and hurries with the shower and helps Miss Sampson get dressed. When she leaves the home, Miss Sampson is still crying softly. Susan documents the care she did for Miss Sampson, packs her things, and goes on to her next patient. Darlene is visiting Miss Story, also a patient with rheumatoid arthritis. The first thing she noticed is that Miss Story looks exhausted. That could be a sign of pain. She asks her how she's doing, and Miss Story says fine. Darlene quickly notices that Miss Story is not her usual self. She seems distracted and doesn't like to talk much. Darlene sees her grimace or time or two as well. She also asks Miss Story directly, are you having a lot of pain today? Miss Story admits that she's been having a lot of pain all night, but she doesn't want to bother her family since they have enough on their minds without worrying about me. Darlene tells Miss Story that she's going to call the nurse to tell her about the pain. When she talks to the nurse, she also asks whether it'll be all right to give Miss Story a bed bath today instead of a shower. The nurse tells Darlene that it's a good idea and that she should not do her exercises this morning. The nurse then talks with Miss Story and encourages her to take one of her pain pills and tells her that she will come see her tomorrow. Darlene asks Miss Story if she would like for her to turn on the radio to her favorite station. She plays the radio softly and turns off the overhead light. She then gives Miss Story a soothing bed bath followed by lotion and a good back rub. She assists Miss Story in positioning herself. She tells Miss Story that she understands how draining it can be to have pain, but reminds her how important it is for the nurse and doctor to know when she is having pain so that it can be managed. When Darlene is ready to leave, Miss Story is more relaxed and says she thinks she will be able to take a little nap. Darlene documents on her visit report about the pain, notifying the nurse why she gave a bed bath instead of shower and why the exercises were not done. She packs up her things and goes on to her next patient. So something to think about. Compare Susan's visits with Darlene's visit. And I'll let you go ahead and do this. List some of the things Susan should have done for Miss Sampson. Let's actually say those things out loud. What are the most important things that Susan failed to do? So Susan was the story up top with Miss Sampson. So what were some of the most important things that she neglected to do?
She didn't accept that the patient was in pain and actually made her go through the exercise.
Right, so she did not accept the patient's report of pain. And pain, again, is what the client or the patient says it is. What else did she neglect to do?
She didn't report the pain that the patient was having.
She did not report the pain to the nurse. What else? She was rushed to go. Correct. So think about some of your patients who have chronic pain. List ways you can improve what you did during those visits and list some of the things you need to write on your visit report about patients with pain. So I won't have you list, but let's talk through. What are some ways you can help patients who are suffering from pain while you're there?
Good positioning.
Positioning. What else?
Back rub if they need it.
Back rub. One thing that gets looked over often, music. So music actually helps relieve pain. Okay? So list some of the things you would need to write on your visit report about patients with pain. What would you need to write on your visit report?
Where the pain was, if it was intense or if it was just something that was coming and going. Also, the nurse that you reported it to.
Right, so where the pain is, if it was coming and going, when did it start, especially if they had an injury while you were there, and the nurse that you reported it to. That is correct. If you flip over to the next page, at this time I'll give you a few minutes to do your questions on this page.